I'm Timothy Donahue. I am a surgical oncologist. I am the chief of the Division of Surgical Oncology at the David Geffen School of Medicine at UCLA and UCLA Health. I'm a very busy pancreatic cancer surgeon. I usually perform 2 to 3 pancreatic cancer surgeries per week. I have a lot of experience taking care of patients with pancreatic cancer. Patients with borderline resectable pancreatic cancer are those whose tumors involve the surrounding blood vessels or vasculature, or at least partially involve the vasculature. The National Comprehensive Cancer Network has specific definitions of what is considered to be borderline resectable or locally advanced, which is just various degrees of involvement of the local vasculature or blood vessels that are around the pancreas, at least in terms of the anatomic definitions. And patients whose tumors do involve blood vessels and have borderline resectable tumors are treated with chemotherapy and or radiation therapy up front prior to surgery. The reason to do that is, in some cases, the treatment can shrink the tumors away from those blood vessels. So when the patients undergo surgery or to have their tumors resected, the surgery is less complex than if one has to remove the blood vessels and then reconstruct them. Also, the other reason to give the treatment up front is to be able to have a period of time where one can assess the biology or the progression of the patient's tumor, much like the rationale to giving chemotherapy before surgery for patients with resectable disease, and to identify those who progress or have very aggressive disease and develop tumors in the liver or outside of the pancreas during that period of time before surgery, to again identify the folks who would not have benefited from a surgical resection. So one reason to give it in patients with borderline resectable disease, one reason to give it is to try and shrink the tumors to make the surgery less complex. And the second is to identify those patients who would benefit from a surgical resection. That being said, I think the numbers usually pan out that about 80% or so or more of patients who are diagnosed with borderline resectable disease are able to undergo surgical resection of their tumors after the upfront period of chemotherapy or radiation therapy or treatment. And identifying who should have the surgery and at what time they should have the surgery is a very complex decision, and again, one that should be made in a tumor board with experts from multiple different disciplines: medical oncology, surgical oncology, radiation oncology, to discuss when it is thought to be the best or most appropriate time. But the duration of treatment for patients is usually at least 6 months in total of a systemic therapy. And again, in the neoadjuvant therapy for borderline resectable disease, it's just taking part or all of that and giving it to patients before the operation. And the metrics that most people look at are a response or a reduction in the main tumor marker that's used for pancreatic cancer, which is CA19-9. Ideally, that marker is reduced or has come down before a patient's brought to surgery. Ideally, that number is normalized, which is less than 35 to 50 or so. And we also look at the patient's functional status and how they're doing, and whether or not it's thought that they can, recover from and tolerate a big pancreatic operation. We also look at the response radiographically. The radiographic response of the tumor to the treatment it's difficult to judge or assess. It's difficult to differentiate, at least on a CT scan or an MRI or an anatomic imaging test, what is viable tumor versus what is dead scar tissue as a result of the treatment. So again, a complex decision that's made on a patient by patient basis for the most part in a multidisciplinary tumor board with experts. If I had to pick one measure that I think most people follow the most, that's clearly the CA19-9 and how that has responded. Most patients get at least half of their duration of treatment before surgery, which is, about the 2.5 or 3 months or so. Some patients, get at least 6 months of the treatment before their operation. And so there's no one standard approach. I'd say it differs from patient to patient, from institution to institution. It's the surgery is timed at the point is what is thought to most benefit the patient, right? It's not necessarily can it be done, but should it be done? And tumor boards come in really helpful for that answer.